All right. So I'm here to set these guys up for the rest of their talk and tell you why what we do is so important. So probably lots of people know this, but I just really want to focus acute heart failure from the emergency department perspective. So what is heart failure, right? It's kind of when you see it, you kind of know it. The AHA, ACC guidelines in 2013 say that it's a complex, constellation of symptoms, signs and symptoms with evidence of cardiac dysfunction. They list congestion, fatigue, edema. You should get an echo. BMPs are great to rule out, but so we're not great at diagnosing it. There was a recent literature review that says people who, even when emergency physicians had a low suspicion of heart failure, 10% were diagnosed ultimately with heart failure. So we're not really good at this. Cardiologists aren't really better at it either. I wanted just to kind of go over some of the classifications. So they've changed even since when I was in residency. We talked about systolic versus diastolic heart failure. Now it's all about reduced and preserved ejection fraction. So anything with less than 40% is your reduced ejection fraction. And then your preserved ejection fraction is above 50%. But there's, the treatment for the two are very different. And most of the trials that you guys are going to be talking about are also focused on reduced ejection fraction because we don't really have much for preserved ejection fraction heart failure. We can talk about the stages and the functional classification. So these are questions that, you should be asking patients. How bad is their shortness of breath? How badly is it affecting their physical activities? Can they carry on their physical activities? And then also kind of the structural heart disease based on their echo. Briefly, again, about 5 million people with heart failure in the United States, over 650,000 new cases annually. We see over 1 million cases in the emergency department. It's about half and half between reduced and preserved ejection fraction. The highest incidence is in African American males. And again, we know this, and I'll go a little bit more into detail. A quarter of patients are readmitted within 30 days, and it's still a 50% mortality once you've been diagnosed in the next 5 years. And unfortunately, we really haven't moved the needle much in any of this data. And again, here, this was a recent updated ACC-AHA guidelines, and you can see for HPEF, there's not much, right? It says treatment, diuresis to relieve symptoms of congestion, and you follow guidelines for their comorbidities. But that's it. Like, really? That's all we have? And then the same thing for reduced ejection fraction. Now you've got diuretics as well. You can add an ACE and ARB, beta blockers, and aldosterone antagonists, but there's really not much new in the treatment of acute heart failure. And so most of these hospitalizations do come through the emergency department, and you can see, so from this graph, so anywhere between 60 to 80% come through the emergency department, depending on the database that you're using. And the numbers haven't changed. In fact, that they're actually kind of creeping up slowly. And this is a paper from Dr. Storo and Chang. And you can see there is some variation. We in the Northeast tend to do, I guess, very poorly in our care of heart failure patients. We tend to admit more of them than, the West, the Midwest, or the South. Academic places admit more than non-academic places. And you can see the non-safety net hospitals also admit more than the safety net hospitals. Here's a paper recently that looks at kind of the changes in hospital mortality with the changes in guidelines. So each of the color changes is an updated of the AHA-ACC guidelines. And you can see there's a slight decrease, but it's really not much. Despite all these new guidelines and all these new rules, we really haven't changed the curve much, if at all. And again, ejection fraction and mortality, while we focus a lot on reduced ejection fraction, they do have a higher analyzed incidence of mortality. These people still do pretty poorly. And so one of the big things that we talk about are readmissions, right? That's the big focus for CMS. That's the big focus for us. I don't know about your hospital, but I feel like more and more patients are being pushed to observation or observation status as opposed to admission. Even though you're like, but wait, like, what do you mean? Like, they look sick. I joke around to my residents and I say patients pretty much have to be dead before they're admitted. So you can see, yes, based on these measurements, there's a decrease in the number of admissions for initial hospitalizations for heart failure. But if you look at some similar time frame data, Observation stays are going up for both these targeted and non-targeted conditions. And then if you look at specifically in heart failure, you can see the number of observation-coded stays are increasing much faster than those inpatient stays, right? And then here's another interesting thing. So observation versus short inpatient stays. So I know it's hard to read, but the observation patients actually tend to do worse than short inpatient stays across the board. So patients are being pushed to observation, but maybe we're just not doing things as well. And again, so this is another thing. So the timing of readmissions, most of these happen early, so we should do more to intervene and help patients transition better to their outpatient care. So in summary, acute heart failure epidemiology, we've got increasing prevalence with our increasing aging population. We haven't significantly changed morbidity and mortality in this population. We're putting more people in observation. It doesn't really look like there's a significant decrease in the number of admissions. It's just how we play the game. And really, treatment hasn't changed. And so do we have anything new? And these are what these guys are going to talk about next.